Now let's get into the central nervous system, and that's what we're talking about here: the spinal cord, the brain into the peripheral nervous system. And remember, we're still talking about communication between nerves, and since these nerves don't actually touch, we have these synapses, and we've got our little transmitters. We've got our communicators going from one side to the other side. So we've got neurotransmitters in that synapse area and binding to receptors on the other side. And when we talk about central nervous system and when we start playing with the central nervous system, give medications that affect the central nervous system, well, we're going to be affecting mood. We're going to be affecting sleep. So, your problems with insomnia can be managed with medications that affect the central nervous system. And then we're also affecting movement and perception of pain. And just like in other areas of the body, medications that we're giving to affect the central nervous system, they can be direct acting, they can be indirect acting. So your drugs can bind directly to the receptor and either activate it, stimulate it, or block it, or they can be indirect acting, and they are affecting the concentration, the amount of the neurotransmitter in that synapse area. So we can block the reuptake, for example, of serotonin. We can have an SSRI, a selective serotonin reuptake inhibitor. And by doing that, this indirect acting medication, we are blocking the reuptake of that serotonin, so there's more serotonin in the synapse for it to activate, to stimulate those receptors a little bit more. So we can do that indirectly. We can also indirectly inhibit the degradation of the neurotransmitter. So there are chemicals in your body that break down those neurotransmitters. So if we inhibit those breakdown chemicals, well, then we have more of that neurotransmitter. So again, just like in every other part of your body, your medications can be either direct acting or indirect acting. We'll focus on a few broad categories of central nervous system medications today. We'll talk about antipsychotics, we'll talk about some stimulants, we'll get into some hallucinogens, and some sedatives or sedative hypnotics. And again, anytime we are kind of playing around with the central nervous system, lots of emotions in there, mood gets into there. So all your emotions, your anger, your anxieties, your happiness levels or sadness levels. Your mood, is it elevated? Is it depressed? So we can affect all of these emotions, and when we get into disorders, very common anxiety and depression disorders, schizophrenia, bipolar disorders we'll talk about. And we can give medications to manage these. We can give anti-anxiety medications, we can give antidepressants, antipsychotic medications, and opioids. We talked about the perception of pain, so we can give opioid medications to affect your central nervous system to affect your perception of pain. But first, we need to talk about neurotransmitters in the central nervous system. They come in a couple flavors. First are our amino acids. So we've got GABA, and we've got glutamate, aspartate, glycine, and taurine. Those are our amino acids. And we have chemical neurotransmitters. And you might already recognize a couple of these: acetylcholine and norepinephrine. They do affect the central nervous system as well. Even though we've talked about them in the autonomic side, they do affect the central nervous system. So we've got acetylcholine, we've got norepinephrine, we've got dopamine as a neurotransmitter, not as a medication. So the medication dopamine different than the neurotransmitter dopamine, but we've got that dopamine there. We've got serotonin, histamine, and we also have endogenous opioid peptides. Now we said norepi and acetylcholine affect central nervous system as well. So as an example, we've got norepi, and we know that norepi binds to and stimulates alpha and beta receptors. We know that norepi and epi do this, but they're also involved in regulation of anxiety, brain function, memory, learning, and even mood. Then we have dopamine, and dopamine as a neurotransmitter binds to dopamine receptors. And there are five different subtypes of dopamine receptors, but we're not really going to dig into the five different ones. We're not going to dig that deep. So just know dopamine binds to dopamine receptors. And with dopamine, the effects when we stimulate dopamine receptors, we have hormonal releases in your glands, but it has a lot to do with mood. So if we stimulate dopamine receptors, we elevate our mood. Then serotonin, and serotonin is going to be the one curveball for you. Serotonin binds to serotonin receptors, but serotonin receptors are called 5-HT receptors. So serotonin binds to 5-HT receptors. And serotonin has a big effect as well on mood, on sleep as well. So you might have a patient on, let's say, an SSRI, that's selective serotonin reuptake inhibitor, to elevate their mood. Maybe they've been diagnosed with depression, or maybe they have some sleep issues, some insomnia issues, so they can be put on an SSRI for that as well. So with serotonin, most commonly, we'll block the reuptake of serotonin with those SSRIs, but we can also give drugs that either stimulate or block these 5-HT receptors. Then histamine, we have histamine and we have histamine receptors. So histamine binds to histamine, dopamine binds to dopamine, serotonin binds to 5-HT receptors. So histamine binding to histamine receptors are a few different types, and the one in the central nervous system, we'll talk about the other histamine receptors. We've got histamine 1 receptors, which are kind of our typical Benadryl type of allergic reaction receptors. We've got H2 receptors in our gut, and think about like heartburn and Pepsid. But we also have H3 receptors in our brain, and in that central nervous system. And what happens when we stimulate H3 receptors, when we stimulate the histamine receptors in our central nervous system, it keeps us awake and alert. So if I give you an antihistamine that crosses the blood brain barrier, we're going to block those H3 receptors, which keep us alert and awake. And if we block those, well, then we get drowsy, we get sleepy, and we get some sedation. So drugs like Benadryl cross the blood-brain barrier, so they're blocking histamine receptors in other areas of the body, but also in your central nervous system, causing that side effect of drowsiness. And speaking of drowsiness, let's get into sedatives. So you have a patient who is tense and needs to be sedated. Well, we can do this in a few ways. We can, give them a tranquilizing medication, and many of our antipsychotic medications are tranquilizing, or we just kind of calm them down and maybe zonk them out a little bit. But they're not asleep. We haven't knocked them out, medically knocked them out in any way. They're not sleepy. We're just calm. And then we can give other medications that make you a little bit drowsy. We mentioned Benadryl there. And then we can give other medications that'll just put you to sleep. And a lot of these medications that we're going to be talking about are very dose dependent. So if I gave you a little squirt, I'll make you a little bit calm, a little bit drowsy. But if I give you a bigger dose, bigger squirt, we can actually put you to sleep and get those hypnotic effects. And when talking sedation, we're going to have to talk about GABA. And GABA, receptor sites for GABA. And so we've got this chloride ion channel, and we're stimulating GABA here. And with our benzodiazepines, that's our Ativans or your Xanax, Valiums, your benzodiazepines, they're going to bind there. They're going to bind to GABA and stimulate GABA. And we also have barbiturates that are going to bind to GABA and stimulate GABA. When we do this, when we stimulate GABA, we are going to slow everything down. So we're going to sedate by binding to GABA. See zolpidem there? Zolpidem is Ambien. So Ambien slows everything down, makes you drowsy, makes you sedate. Just in table form here, a number of medications typically prescribed for insomnia. You've got Lunesta there at the top. It's pretty common one. You've got Ambien as well. So Ambien a little bit shorter acting. So Ambien, depending on your insomnia, Ambien will put you to sleep, but won't keep you asleep because it's got a short half-life. Lunesta will put you to sleep and keep you to sleep because it's got a longer half-life. So just know your insomnia drugs are here with GABA. All right, now let's talk hypnotics. And we've got these sedative hypnotic drugs. So they're sedating, they're hypnotic, they can put you to sleep. And we're going to be giving them for acute anxiety, acute phobias, and OCDs, obsessive compulsive disorders. And just remember, we have patients that walk around and live every single day with anxiety disorders and phobias and OCDs. And on the 911 side, as paramedics, we see these patients at their extremes. So when there is an extreme event, that's when we're going to encounter them. And these are some of the drugs we can use to manage those states. So just know these disorders, excuse me, these disorders are on a spectrum, and we typically see on the 911 side, we see these disorders on the at the extreme. So we can give benzodiazepines to sedate, right? Your Xanax, your Valium, Ativan, Versed, all your Lambs and Pams. Those are going to be your benzodiazepines. We can give barbiturates, and the most common one you'll see is phenobarbital. So your barbiturates and benzos both affect GABA, just in different areas. So if our benzos aren't working, those are usually our first line. If those aren't working, we can go to our barbiturates. So instead of going through the front door, we're going through the back door. So same end effect, just in a different area there with GABA. We talked about those antihistamines, the ones that cross the blood-brain barrier, like diphenhydramine or Benadryl. We can give those to sedate a little bit. Not huge sedative effects, but they are there. We'll mention real quick a couple other little sedatives, chlorhydrate, melatonin here in a minute, and then we have anti-anxiety medications that are non-sedating, like buspirone, and propranolol that we'll hit here in another minute. So what we're doing here with these medications, these antipsychotic medications, we're blocking a whole bunch of stuff. We're blocking dopamine, we're blocking serotonin, we're blocking histamine, and so when we do that, we're not alert, we're not anxious, we're not stimulated. So remember, dopamine and serotonin affect your mood and your activity and your alertness. So we block all of these. We block dopamine receptors. We block 5-HT receptors. We block histamine receptors. We're gonna sedate you. So your antipsychotic medications, a whole bunch of them out there. But a couple to be aware of there at the top is Thorazine, somewhat popular in the hospital. All the way at the bottom is Geodon, also pretty popular, and you might see it in the hospital. On the truck, though, right there in the middle, we're going to be giving haloperidol, Haldol. That's a pretty great antipsychotic medication for our purposes. Then another list of benzodiazepine drugs for you are benzos. So our benzodiazepines, all of our lambs and pams. So you've got Valium, you've got Xanax, Ativan. Versed falls under this category as well. Very popular anti-anxiety drugs here for you. So again, please don't memorize all of these daily dosages, but we'll be covering in your other courses. We'll be covering our dosages for our protocols on the truck. So our benzodiazepines, our benzos, you'll see your patients on these for chronic anxiety. Maybe they just take a benzodiazepine, maybe every day, maybe just when they're feeling a little anxious. They'll take it. Also, really, really great medicines for patients who are withdrawing from alcohol. So, Ativan or lorazepam, It's typically our first line drug when we've got a pretty bad alcohol withdrawal patient. You can give it for insomnia. They will put you to sleep, and again, that's dose dependent. So put it to sleep. And then on the truck, we're going to be using benzos, probably the most commonly for seizures. And so benzo is going to be our first line for seizures. And then we can also use benzos for anesthesia, especially conscious sedation. So conscious sedation where it's not general anesthesia. So we're sedating this patient, kind of putting him to sleep, knocking, kind of quote unquote knocking him out, but the patient can still maintain his own airway, and we're not worried about desaturation. He's still breathing, patient's still maintaining their airway, but not feeling much or any pain, depending on the procedure. So if you have someone who, like me, dislocated the shoulder, and you need to reset it, pop it back into place, they're going to put that patient under this conscious sedation, because popping that joint back into place isn't the most comfortable thing. So we can give benzos for conscious sedation, and then wait for it to wear off, and then discharge the patient. So benzos, again, binding to those GABA receptors, and when we bind to GABA receptors, we slow everything down, and we get sedation. So benzos are on those omega receptors. Remember, benzos and barbiturates both bind to those GABA receptors, just in different places. So our benzos are dose dependent. So I can give you a little squirt, I can give you a big squirt, and get different effects. But we're going to get drowsiness, we're going to get maybe a little dizziness, depending on the patient. Motor incoordination. So just pay attention to your patient when giving a benzo, and we're definitely not going to give them a benzo, then discharge and kick them straight into the car and tell them to drive home. So there is going to be drowsiness, there is going to be motor and sensory issues. Then our barbiturates, again, still binding to that GABA receptor, just in a different place than our benzos. So both benzos and barbiturates, same end effect, same receptor, just in different places. So now you might be thinking, well, what's the difference between the two? Why would I give one over the other? Well, barbiturates have more severe and more common side effects than do benzos. So barbiturates, a lot of sedation, and if you're taking it for, let's say, insomnia, um, so you take it in the evening to go to sleep. Well, even when you wake up after a full night of sleep, you're still going to be a little like foggy, and you're going to have a little barbiturate, quote unquote, hangover, and you're just going to kind of walk around a little bit of a fog. So sedation affects. A little bit more than those benzos, and just kind of causes those hangover effects. So we've kind of gone away from barbiturates for the most part and towards benzos, but you'll still see them out there. So patients on these at home for insomnia and anxiety. Then your patient can also take antihistamines for some sedation for insomnia, let's say, because remember our older first generation antihistamines like Benadryl, diphenhydramine cross the blood-brain barrier, and when we block the histamine receptors there in the central nervous system, we get sedation. A couple other sedating medications. We've got chloral hydrate. It's an older medication. You might still see it in the hospital used in pediatric patients for some sedation. But what it's kind of best known for now, if you've ever seen, probably in TV or movies, someone slipping them a Mickey, right? We've got a Mickey Finn. So if they get slipped a Mickey, that is chloral hydrate that's been put and combined with alcohol. So this is kind of a sedating drug where you take chloral hydrate, put it in someone's drink, and you knock them out. And that's slipping someone a Mickey. So if you've ever encountered that, TV, movies, or just heard of it, that's what it is. So that's your trivia for the day. Then there's melatonin, and melatonin you can get over the counter. You can run down to CVS right now and grab a bottle of it. So your body makes melatonin and releases it when your body and its natural biological clock say it's time to go to sleep. So your body releases melatonin tells your body that it's getting sleepy and drowsy and you should go to bed. So we can take this, we can take this PO as a pill, go get it over the counter, and we can take it and then tells our body to go to sleep. So it helps us get to sleep at night. And then we mentioned a couple anti-anxiety drugs, but they weren't sedating drugs like the other ones, like your benzos. So we got buspirone. That's a partial serotonin agonist. So, gonna kind of a little bit stimulate your serotonin receptors. Um, and have this anti-anxiety effect, but we don't have any sedation along with it. So you can take it every day. We're not walking around in a fog or not walking around with sedative effects. Same thing with propranolol. So you notice propranolol is a beta blocker. And it's one of our non-selective beta blockers. Well, why would we be on a beta blocker for anxiety? Well, when you have an anxiety attack, or issues with anxiety, we've got extra squirts of adrenaline. We've got epi, norepi being released during these events. And well, epi, norepi go around and bind to your receptors. Well, if we're blocking some of those receptors, like our beta receptors, we're not going to have those cardiac effects. Your heart rate's not going to skyrocket. Your blood pressure is not going to go up with in an anxiety event when you're on propranolol. So patients might be on propranolol for a cardiac issue, or they might be on it for an anxiety issue. All right, now let's move along into some antipsychotic medications. We're going to be using these for patients with schizophrenia, maybe drug-induced psychosis. And then we're going to be seeing bipolar disorder patients, typically in the extremes, extreme manic stage, or maybe extreme depressive stage. And also, dementia patients are prone to some pretty severe agitation as well. And again, remember, just a reminder that patients are walking around every single day, managing schizophrenia, managing bipolar disorders. And on the 911 side, we are seeing these patients in their extreme states. So we're going to be called out for extreme events, but you have people around you every single day walking around with these disorders. So the day-to-day management of schizophrenia, we're not 100% sure of what causes schizophrenia, but the leading theory is this dopamine hypothesis, and that there's just abnormal dopamine activation, stimulation, and in the brain and in lots of parts of the brain. So when we're managing schizophrenia chronically, long term, day to day, the medication goal here is we're going to block dopamine receptors and or block serotonin receptors or 5-HT receptors. And on the truck in the hospital, we can block dopamine receptors. The big one here is going to be that haloperidol. That's Haldol. So we'll be giving this on the truck. Haldol is going to block dopamine receptors and sedate your patient in these kind of extreme events. A big side effect to Haldol and these other drugs, that these typical antipsychotics that block dopamine receptors, are extrapyramidal symptoms. And these extrapyramidal effects, you'll see this. There are a number of medications that cause this. So you give your Haldol, and then you might see your patient starting to kind of contract and kind of scrunch up maybe one side of their mouth, one side of their face, and into their neck. So if you see those muscle contractions in their neck and their face, you know that's an extrapyramidal symptom. And what we're going to do for that is give Benadryl. It's a type of allergic reaction, and we're going to be giving Benadryl to fix that extrapyramidal effect. And when you're in the hospital, probably see patients being given Haldol, and the nurses are going to give Haldol and Benadryl at the same time. So they don't have to worry, because pretty common to see extrapyramidal symptoms when we give Haldol. Then we have atypical psychotics, or excuse me, antipsychotics. So we've got our typical antipsychotics, and we have our atypical antipsychotics. Your atypicals are going to block dopamine receptors, and they're going to block serotonin 5-HT receptors. These drugs are atypical antipsychotics, less chance, less risk of extrapyramidal symptoms, so we don't have to worry about that as much. But they also take a while to really see their full effect. So, patient goes on one of these, daily regimen, just managing schizophrenia on a day-to-day basis, let's say, and it might take a month to 2 months for these drugs to reach their maximal effect. And side by side, we've got our typical and our atypical antipsychotics. And so our typicals, they're the older ones, they came out first. We're worried about extrapyramidal symptoms, but our typical antipsychotics block dopamine receptors only. Our atypical antipsychotics block dopamine receptors, but also those 5-HT serotonin receptors. And so our atypicals, they're the newer medications. We're not as worried about extrapyramidal symptoms, and they're blocking dopamine receptors and those 5-HT serotonin receptors. Then moving into bipolar disorder, your patient's going to be on medication um, to manage bipolar disorder. It might be on lithium. So that's a really good drug for bipolar patients. We're not really sure on how it works, but it works, so we use it. Issue with lithium, though, is that it's a very narrow therapeutic range, therapeutic index, so very easy to either underdose and not get the desired effects of the medication, or um, more risky is the overdose. So very easy to overdose even accidentally and go above that therapeutic range. And when we overdose, lithium has a lot of cardiotoxicity to it. So easy to throw the patient into cardiac arrhythmias and eventually cardiac arrest. So patient is on lithium, they should be monitored pretty frequently with blood testing to monitor their serum levels and make sure that they're in that therapeutic range. Your bipolar patients might also be on benzodiazepines every day to manage their bipolar, or maybe just benzos PRN when they're just feeling a little out of sorts, right? And then they also might be on an antipsychotic medication, like one of these atypical medications that blocks both dopamine and serotonin 5-HT receptors. All right, now let's get into some antidepressant medications. And with these mood disorders, your patient's diagnosed with depression, so you've got this depressed mood, kind of feelings of this worthlessness. Insomnias are very common with depression. Anxiety is very common with depression. And what we found is there are a lot of abnormalities with serotonin levels, with norepinephrine levels, and or with dopamine levels. And to treat and manage depression day to day, patient might be prescribed a tricyclic antidepressant or a TCA. So, two big ones here, amitriptyline and nortriptyline. So, all your triptylines are your TCAs. So, patient might be on amitriptyline. And what amitriptyline or nortriptyline, what these TCAs are doing, they're blocking the reuptake of serotonin and they're blocking the reuptake of norepinephrine. And so we get extra receptor stimulation and that elevates your mood. Problem with TCAs, just like with lithium, very narrow therapeutic range. Easy to overdose even accidentally on TCAs. So once we overdose on TCAs, we go into cardiac arrhythmias, go into cardiac arrest, and we die. So TCAs also block sodium channels, and when we think about that beautiful action potential, cardiac action potential in your cardiac myocytes, well, if we're messing with sodium channels, we're going to be messing with that action potential, and that's why it throws you into cardiac arrhythmias if we go toxic on these TCAs. So they're older drugs, not frequently prescribed frontline quite as often anymore, but you might see your patient on an amitriptyline or nortriptyline. Instead, more common now are your SSRIs to treat and manage depression, so your selective serotonin reuptake inhibitors. So these, well, they block the reuptake of serotonin. So there's more serotonin in that synapse, that synaptic area, and we can we can stimulate, we get excess serotonin 5-HT receptor stimulation, and that elevates your mood. And you might recognize a lot of these SSRIs like Prozac, Zoloft, or Paxil. These are all SSRIs which block the reuptake of serotonin. We also have some newer generation SSRI drugs. If you've heard of Wellbutrin or Cymbalta, you might have seen their commercials on the TV. But these are just newer generation. They're still selective serotonin reuptake inhibitors. All right, if you have any questions, comments, concerns, or cuss words, please let us know.